Okay, hello everybody. Good morning, good afternoon, good evening to you all, wherever you are in the world. On behalf of the International Society for Equality in Healthcare, I'm absolutely delighted to welcome Professor Jason Leitch and Dr. Dominique Allwood, who will be speaking about the UK's national response to COVID-19. We're absolutely delighted to have you both with us today, and thank you again for joining us. By way of some short bios, Professor Leitch has worked for the Scottish Government since 2007, and in January 2015 was appointed as the National Clinical Director in the Health and Social Care Directorate. He is a Scottish Government Director and a member of the Health and Social Care Management Board, and he's one of the senior team responsible for the NHS in Scotland. Dr. Dominique Allwood is Assistant Director of Improvement at the Health Foundation and Consultant in Public Health Medicine and Quality Improvement at Imperial College Healthcare NHS Trust. Dominique is a doctor by background and has spent 14 years working in various parts of healthcare, including provider and commissioner organisations, think tanks and national bodies. So this session is an Ask the Expert Q&A session, so we encourage everyone to join in, say hello in the chat box, and please use the Q&A box to ask any questions that you might have. So guys, again, thank you so much for joining us, and we'll jump straight in, I guess. So how are your healthcare systems coping with COVID-19 right now?
So maybe I'll do a national picture across the UK and Scotland in particular, and then Dom can maybe help us with what it feels like to be in one of the actual boards and trusts where they're having to face this crisis at a slightly different level. So almost uniquely, the UK is tackling this as 4 countries. So those of you from around the world will maybe not realise that we now have very distinctive national health services across the United Kingdom, 4 very different ones. I am the clinical director of the Scottish one, but the ministers at political level and the senior teams at clinical level, the chief medical officers, the clinical directors, the nurse directors, are working very well together as a 4-country block. So we're trying to follow the science, we're trying to do that in an evidence-based way, and we're trying to be ready on a 4-country basis. That, of course, looks different if you're in Orkney from central London. So we're contextualising that to the individual places. But in the main, we're following the advice as a 4 UK country, and the population advice, we're trying as best we can to do that together, because if we do procedures around large gatherings or around how we protect the vulnerable, then we're trying to do that particularly at a 4-country level. So the health services are managing that pretty well. They're ready. They're working well, but it's a challenging time. It's literally unprecedented. I have never in my career, and the people even older than me have never known anything at this scale.
Okay, I think over to me. So my experience is that I've been working in an acute hospital trust in England, a large teaching hospital in northwest London, and my role is as Associate Medical Director and as a consultant in public health. So I have some responsibility and involvement in how we think about the management structure within our organisation and how we think about COVID within that, and also at a population level, thinking about the system and how we're thinking about patients and staff across that. So for us, I think the key turning point was about 2 weeks ago when we realised that we were going to have to do some things differently as a health service, that this pandemic was really coming. And how do you start to organise your teams, your staff, and think about your flow of patients in a different way to the day-to-day basis in which you've been running things up until now? So the first thing I think was that we went into a command and control structure. So those usual meetings and priorities that we have as an organisation pretty much went out the window very quickly, and we started in a new way of organising decision making and looking at our data and evidence. I think what's become obvious over the last 2 weeks really is that we've had to think differently about how we work with our staff and move them into areas of greatest need across our organisation. So whether those are people that need to step up into roles that require more acute or specialist care, or escalated care into more intensive settings, and that's taken quite a bit of change for people to think about their new roles, and many of our non-clinical staff having to move in and support those roles that were traditionally done. The other thing is thinking about flow of patients. So very early on, when we were trying to contain the virus and think about contact tracing everybody and understanding where people had travelled from, and that feels like a long time ago now. But we had patients coming into the front doors wanting to be tested, and we had to do lots of that checking. And then once we had large groups of patients who were coming in with confirmed or suspected COVID, we had to think about a whole new flow through the hospital. So how do we have areas where people are cohorted together? And then how do we actually make the hospital run in what is our new normal for now, which is having patients who are sick with COVID, having other patients who still have other diseases and illnesses, and how we maintain our quality and our services in such a way that helps support this new model of care whilst recognising that we have to do something different. One of the things that has been put into place in London, which many people will have seen on the news, is the new Nightingale Hospital, which has been really thought of as the extra surge capacity for these very sick patients that are coming through that are needing intensive care support. And our hospitals are now working out how they would use that extra capacity and also work in a different way together across their sectors and systems. So traditionally, our hospitals have thought about how do we get activity into our beds and doors, because that's very important for us. Now we're having to think about, well, how do we share and best place our resources to do this much more as a system? And I think, given that this has only been about a 2 or 3 week period, that we have really transformed the way in which we're doing a lot of care at the level of the system and for the individual patient. So many people now will be getting virtual outpatient consultations. Many of our staff are working in different ways remotely. And so whilst it's feeling very acute and pressured, there have been some fantastic things that have come out of that. But in the main, at the moment, I feel like particularly our hospital and the London system is coping, but that's because we swung into action very quickly and put some things into place. So we've been waiting for this peak to come now.
Excellent. Thanks to you both. I don't know where we begin with this one, but what has been the biggest challenge so far in both of your localities?
So the generic size challenge is pace of change, no question. So the pace is unprecedented. The media and the news are focused on the intensive care change, the ability to buy ventilators, the ability to get beds and staff for that intensive care. The reality is that is of course true, but that has implications the whole way through the system. We have had to change the way we do the prison service, the way we have to do the criminal justice system, the way we do education systems in this country, the way we do transportation. So the health advice, the public health advice for those elements at a population level is like nothing I've ever known. It's like nothing I've even read about how to do. So the pace at which we're having to make changes and the politicians are having to make decisions is completely unthinkable 3 weeks ago. So we have completely transformed the health and social care system in 3 weeks. I honestly didn't think that was possible. If you told me 3 months ago that Scotland could quadruple its intensive care capacity in 6 weeks, I would have thought you were crazy. If you told me you could reduce the delayed discharges in this country by a third, so we've gone from 1,900 delayed in hospital, and we've got 600 of them out of hospital safely to other areas within 3 weeks, plus everything in between, increasing general care, increasing cancer care and putting it somewhere else, all the other elements that you would expect. And at the same time, we've invented a whole new system for the support of local businesses. We've managed to get schools into hubs so that critical care workers' kids can still go to school, but the rest of the kids are safe at home, and everything else you can imagine in there. How do you deal with the prisons? How do you deal with the criminal justice system? What do you do with the national parks? So all of those decisions at an astonishingly fast pace have had to be done. So the biggest challenge, I have no doubt in my mind when the history is written, is the speed at which we have to make decisions. And the great thing about being on social media and being in the media, of course, is you have the privilege of not having to make those decisions. So those of us in these seats have to make those choices, and we have to make them fast.
So for us, I think at a local level, there's been a few challenges. One has been around the anxiety, particularly of staff, around their risk to the infection, thinking about getting access to personal protective equipment and testing. And those have been big challenges to overcome. Some of that is real, in that there have been places where we've had to move stock and equipment around, and that takes a bit of a lag time to catch up. So staff in places may feel a perceived squeeze on what resources are available. And I think some of it is about the communication and messaging. So when is it appropriate to wear the right things? When is it appropriate to have the testing, etc.? So comms is a big piece of this, about why are we doing things in a certain way, being very evidence-based and being clear, but making sure that people believe and understand those messages and feel that they are safe to be able to do their role. So the testing piece has been very live for us. How do we get enough staff to be tested and have that safely happening alongside our patients? And I think that whilst it's very important on a population level to know those figures and numbers, we need to be quite careful about what the purpose of testing is and how it will change management. So will it help people to know that they can come back to work sooner? Will it help us change how we're behaving with the patients that we're looking after? And I think that kind of softer behavioural thing that underpins some of the bigger policies has always been important, but feels even more important to convey about why we're making choices around what we do. I think one of the other things that we have to think about as organisations is how we maintain quality and what quality looks like in this new situation. So how are we understanding whether the deaths that we're seeing are related in the main to COVID, and whether that would be what we'd be expecting to see, or whether there may be underlying issues of care that might be contributing to other things that we wouldn't necessarily detect, because our emphasis and effort is on very much trying to manage the acute situation. So how do we keep an eye on all the things that we should be doing and make sure we're delivering a good quality system? I think the other challenges around making sure our staff feel supported, they're being asked to do new roles at short notice and having to train them very quickly is really important. So all across the whole of the quality domains around safety, patient experience, staff experience, making sure that we have the right outcomes. And what does that look like in a setting or system where things have changed and they keep changing? So the other big challenge is that we have uncertainty around how fast this problem is going to escalate and the numbers that we're looking at. So people have to manage with a certain level of ambiguity and complexity with changing messaging as we move through the pandemic. And how we do that, keep agile, keep communicating, and make sure that we make those changes quick enough to keep up. It's a real challenge.
Excellent. Thanks to you both. Dominique, just to touch on what you mentioned there, our first question in has asked, how will you measure the unintended consequences for people with long-term conditions and not COVID? Are you measuring increased morbidity and mortality there?
It's a really good question. So we're having a look at the moment about the types of data we collect in hospital. And I think it's fair to say that hospital data sets are not always useful in us understanding long-term morbidity and outcomes. We look at things like readmission rates and we look at things like death rates, but actually we hope that in the main those two things will be quite rare. So understanding at a baseline level, how do hospitals know whether they're providing good quality of care, and tracking outcomes for patients has always been quite challenging. And I think even more so during this COVID period. What we want to make sure is that when we're seeing a rise or an increase in mortality, this is because it's due to what we would expect with the volume of patients with the sickness we see, not that there are issues around quality or that other conditions are getting missed. And the anxiety we all have as healthcare planners is that we want to make sure that patients who really need the care are getting it at the right time. So the worst things that could happen are that patients hear the advice, for example, to stay home for 7 days with a fever, thinking that they shouldn't see anyone for medical treatment or help, and they get worse and worse and present very late or not at all, and they have adverse outcomes because of that. So these are things that you've got to balance whilst you continually think about the patients you're seeing through the front door and treat. Did they come at the right time? Did they come too soon? Did they come too late? And we've got a whole cohort of patients now who are coming through, some of them having quite escalated care, being ventilated for a period of time, and we don't necessarily know much about the disease and its prognosis. So how these people do when they're being sent home and released into the places that they live and have ordinarily been, and whether they go back to their function that was previous or whether they need different types of care and support. And then we've got all the usual health and medical conditions that carry on happening, like heart attack, stroke and cancer, how we make sure that we're managing those as well as we can with the demands on our resource, but also how we're making sure that we don't have too many adverse outcomes. Now, many of you will have seen Jason talking on the news about the fact that some of the cancer screening programs have had to pause. That's a really important and difficult decision to make, and we need to make sure that we're looking at rates and incidences of presentation of that, and making sure that the messaging is very clear about how we then go back and look at that surveillance. So I think it's balancing a lot of things and trying to get data and make decisions about what the right course of action is to do, but look at all of those unintended consequences. And as improvers, which many people are on this webinar, we know that it's really important that we're looking at the balancing measures of the decisions that we're making.
Excellent, thank you. So our next question from Anthony Staines in Switzerland. So what do you see as the role of quality and patient safety departments in response to COVID-19? And he said he sees a number of quality and safety officers a bit lost about their role at the moment. Some are at home, some are helping to care for patients, and not many are running patient safety.
So Anthony, hi, I hope you and the family are well in Switzerland and keeping safe. I think it's a really interesting question. So everybody's role has changed in this new fast-paced environment. Even in a conversation I had, would you believe, with Don Berwick is struggling to know what to do. What do the icons of the safety and quality movement do when the world looks like this, when health and healthcare looks like this? Never mind the patient safety officer in a small community setting inside Scotland or wherever. I think there are some things that cohort of people can do. Number one is they can go back and be fully clinical if that's what's required. So my head of person-centred care is back being a senior intensive care nurse. So for the moment, that is probably the right place for him to go. Not at the expense of all of the person-centred care work in Scotland, but he is, for the next few weeks, better placed running a person-centred intensive care unit. The second thing they can do, I think, is very fast evidence and evaluation. The quality movement is really good at agile gathering of global evidence, putting it into a form that isn't long and long-winded. And I think ISQua have been really good at that. I read their Italian paper just a couple of days ago. That was hugely helpful for what we've called our clinical cell. So we have a senior clinical cell in the country that is doing the clinical advice to all of the other intensivists and all of the other community GPs and all of that. So ISQua and others like ISQua have to be really fast and agile about that evidence. But we don't have time. We don't have time to read long documents. We don't have time to think about where your evidence came from. We need fast, quick, agile, quality assessments. And we know that will change tomorrow when we get more information from Italy or from Scotland or from Germany. So we need to know what to do and how to do it fast. And then the third thing that quality and safety can do is remember, just because we're working at pace doesn't mean we shouldn't do high quality and safe care. So we're working quicker, but actually we still want all the processes in place as much as we can to still report adverse events, to still do person-centred care to the best of our ability. In fact, you could argue that things like end-of-life care, anticipatory care plans, long conversations with patients and families about cancer care, particularly futile end of care, are all the more important during this crisis than they were just 6 weeks ago. So I think there are things safety and quality people can do, but it's going to look a little bit different for a little while. And it's going to be pacey, for lack of a better description. It's going to be fast.
Great, thank you, Jason. Just to touch on the learning theme then, we have a question from Susie asking, how is the learning being captured both nationally and locally?
So, hi Susie, a really good question. We've been thinking about what does it mean to be in a learning system or organisation during this time. And I think at a fundamental level, I'm a fan of really basic models. We've got at the bedside and the things that are closest to the patient and the staff delivering that care. Is there anything that we're seeing that isn't what we're expecting, or there are uncertainties or gaps in what we need to be doing? And then we need mechanisms and ways of feeding that back up into the system to make sense with data that we would routinely collect and new things that we need to collect. Have a way of then bringing in intelligence into that decision making, whether that's the things that Jason talked about, like the rapid evidence, horizon scanning, looking at what others are doing and bringing best practice in, and then bringing that back down again to make decisions and change that help people do something different. So that fundamentally is the very kind of crude elements of the learning system. I think what we're trying to do, particularly in my hospital, is learn from our data and learn fast from what's going on that people are reporting to us. Think about how we need to make change and understand where we're missing evidence and data on that. So looking at the best practice from the academic institutions and where others are doing things well. And then how we push that out and get that out into the bedside is really important. So many of you will be familiar with your sort of trust intranet, where they'll put a little flag up with some asterisks words that says new, the guidelines have been updated. We need to think about, in this new way that we're delivering care, about the changes that are happening so quickly as to how we get that out in the most accessible ways so that people can learn what we need to do differently. And I think that is the challenge. I think we're getting quite a lot of data in and understanding that we need to be doing things differently and then making decisions based on that. But I think it's how you mobilise that knowledge and learning back out to make change happen fast and keep track of what you're doing, so that these planned experiments and the things that you're doing that might look like very rapid PDSAs are collated, synthesised, and that you're getting themes out of it so that people can understand across an organisation or set of wards or a system that there are patterns and that we're recognising those. Because I think this type of way in which we're working is really new, and as Jason said, it's we haven't worked at such pace, but actually gives such a good opportunity to do things like learning, bring in more rigour around effectiveness and data-driven decision-making. And so I think it's for organisations and the teams that hold a lot of this, often quality effectiveness teams, improvers and others, to be thinking about what's their role and part in this kind of new way of thinking around the learning system. My dream and ideal aspiration would be that someone would be following me around, basically watching all these changes that go on, capturing that and then replaying that back to us, because we can only capture so much from the kind of the basic standard reporting that we have through the incidents and other things. But it's also all the qualitative changes that are going on, the way in which teams are behaving in a new way, the routines that they're doing, the types of conversations that they're having, and the way in which data and information and decision making is changing and flowing through our organisations. And that's the piece of learning that I'm really keen we don't lose in the rapid rush to try and deliver the care really well. So that might sound a bit conceptual and abstract for those who are really pushed at the front line, but I think a role for many of us who might be on this webinar to sort of play in trying to capture some of that learning is really important.
Excellent. Thanks, Dominique. We have quite a few questions and comments coming in regarding clinician mental well-being and physical well-being as well. There's quite a few of them, so I might just put it out there broadly and just ask, how do you think it's being handled at the moment, and is there support systems in place?
So it's a great question, and it's really difficult. We have support in place. We had it before this, and we have it now, and we've bolstered it. We've put money into it. We've got helplines for mental illness. We've got helplines and peer support groups for each of the specialties. We've got as much as we can. We're finding everybody wanting to volunteer to run faster, everybody wanting to do more. In fact, it's all I can do to get intensive care to hold back, actually, to stop running towards the problem and wait for the problem to come, because the population health measures are now in the UK having an effect. So the wave that's coming is still coming, but it's smaller than it was going to be, and it's delayed. So some of the tension is actually because everybody wants to get started. Those deep in the front line who are facing that wave already are finding that challenging, and you can see that around the world, where the countries that unfortunately for them had to go first. Each of us that are in the second, third, fourth wave of countries have learned as each country has had to go first. So every country that does this job gets better on the back of the country that went before. And that's where organisations like ISQua and IHI and lots of others help us. I think you have to expose those challenges amongst the workforce, from the physiotherapists through everybody else, the dentists, the optometrists, the doctors and nurses, to expose what they're feeling challenged about. Your communication has to be as good and as frequent as it can possibly be. And you have to also think about the public. Everything we're doing here is in the public eye. The health services have never been more prominent. The only news story is this. There is nothing else in the news. So you're trying to do two things at once. You're trying to reassure the public and the health and social care workers at the same time, and you have to have different strategies for both. So put in place everything you need. Use your occupational health. Dom will maybe tell the story of her own occupational health helpline once she puts her light back on in her room that keeps going off because she doesn't move enough. And then how you do doctor and nurse support might be very different from how you do police officer, fire officer support in each of these settings. But you have to support them with everything they need, because if they go off, we're in even bigger trouble than we are already.
So I can say a bit about some of my experiences in this, and I think it's so fundamental. This is people working in really high-pressured environments. They're being asked to take on new roles. They're often worried about their family or loved ones. They're thinking about the risk to them just travelling into work, let alone being in areas where they're exposed to patients who are confirmed or suspected with COVID. So there's a lot of anxiety, understandably, about this situation, and people's psychological responses to that will be different. They're also having to make a lot of difficult decisions, often under pressure, and thinking about some of the support they need for that. So it touches so many areas of people's lives, and there's no one catch-all answer to that. A few of the things that we've been putting in place in our trust, one is a decision support service to help some of our clinical colleagues who are having to make these really tough decisions where the families and patients may not agree with what the clinicians feel is the appropriate course of action, or where clinicians are having conflict about what should be done in terms of the patient's best interest for management, or where everyone might agree with what they would want to happen, but once we maybe move into a situation where resources become more constrained, that becomes more difficult to enact. And that burden on our staff is really big. So we've been putting in some support for that, to run a 24/7 hotline for our consultants to get support to other colleagues who can help them work through those decisions and choices, and support the families to be part of that with patients. I think the other thing that Jason said is we're really keen to support people through the kind of occupational health and psychological and psychiatric support and physical health part, but we hope that we're trying to prevent people getting down that road of getting too far, needing that support. So we obviously absolutely need to put interventions in place to support those people who are struggling, but we do really need to remind ourselves about the preventative stuff that we need to do, and think about the importance of, the wellness packs that are going to wards and all the lovely free food that's being donated to our NHS staff, and think about them having access to the accommodation and transport to get home on late shifts, and the fact that they're getting pressure sores from wearing this personal protective equipment for hours on end. So there's the physical, the mental, the well-being. It's such a complex area, and there's no one solution to it, but staff welfare, I think, and staff experience is absolutely crucial during this, because our staff are our biggest resource, and if we can't look after them properly, that we have no hope of getting through this situation. So we've got a few things that we're doing locally, but I think people can always be doing more, and I think they need to be thinking about the broadest ends, from prevention all the way through to dealing with the most severely harmed people who are working in this area.
Excellent. Thanks to you both. Just to touch on that, Dominique, what you said about the full body PPE, I see we have a question from Sue Hignett, who I know we've dealt with before as an excellent human factors expert. She's asked, for staff wearing full body PPE, are you adjusting their working hours, for example, shorter shifts, regular breaks, to make sure that the additional physiological load of wearing the PPE is accounted for?
It's a really good question. I think many people will have seen the study that came out recently, or the piece of data that came out from China that looked at the different shift patterns where staff were working in personal protective equipment for 12 hours versus 8 hours, and those that were working for 12-hour shifts saw something like a 42% sickness and absence rate, and when you reduce the shift times to make them shorter, that went down to about 10 or 15%. Forgive me, I don't have the exact data, but it's a really important question about how we understand our resourcing and the way in which we look after people through the patterns in which we put them onto shift and the environment in which they're in, that will have the biggest impact on how we help support them to deliver their jobs. I think if I'm honest, some of our HR teams are trying to work through those real life problems. They've got so many complex challenges about how do they move staff who haven't been doing particular roles into new roles, how they make sure that those people are deployed in the right places across the system, and then how they adjust their working patterns to do that. Not only would that be complex anyway, but they're struggling on the background of a huge number of staff being off sick and isolating at home for household contact. So it's an absolutely huge, massive challenge. And I think the more that we can get evidence-based decision-making into how we do that work through rapidly understanding where it's working well with our counterparts across London, across the UK and internationally, we'll have a much better chance of making these models really fit for purpose, because we have to think differently and in a new way. We can't just roll out the same shift patterns and ways of working, given that people are being asked to do a completely different way of working for themselves personally. So I haven't got all the answers. We are definitely looking at that in our trust, and I know lots of other organisations are too.
Excellent, thank you. Our next question from Susan, again, follows on from that, Dominique, what you mentioned about the system and shift patterns changing. As you've both described, systems, organisations and teams have already changed the way they are working. Which of these changes do you think will be long-standing changes, and what will be part of the new ways of health and care working in the future? For example, will we see 5-day working shifts again?
I think, so I was asked relatively recently in a media appearance, did I think a pandemic was a good thing? And let me be very clear, pandemics are a bad thing, almost entirely a bad thing. But inside that crisis and inside the work that we're doing, despite the tragedy of deaths and harm, I think there are some redesigned things that will be long-lasting and will help us. There are some obvious ones like video conferencing and phone triage and others. We've gone from 300 video appointments in Scotland a day, 300 video conference appointments in secondary care to 5,000 yesterday. So we're doing a load of our outpatient appointments now virtually in a system called NHS Near Me, which I don't think we will roll back from. We've put the kit in every general practice. We've put the kit in every outpatient clinic, and we've done that really fast. We've done it with technological partners who have helped us and training for the staff, and everybody loves it, including the patients and families. So I don't think we'll roll back from that. I don't think we'll put the delayed discharge people back in the hospitals. So the 700 people who got discharged in the last 3 weeks, they're not going back in unless they deteriorate. And I'm hoping that way of working with more home care, more care at home, will continue. The broader question Susan asks around what will the overall health and social care system look like, I think is intriguing. And I think it's one of the things that organisations like ISQua can do to try and retain some of that knowledge for us as we all take, frankly, a bit of a holiday after the summer, because I'm done for October. I'm done. But so something has to teach us what that's going to look like and what we can learn from it. But it's important to bear in mind that people are dying and people are suffering deeply from this all over the world. So we don't want to be saying, look what we've learned from the pandemic. That doesn't seem like the right language to use. But I think there will be things that we can continue that will help our health and care systems around the world.
Just to add to that, I think the few things that I've seen that I really hope we do retain, I mentioned it earlier, I think new and agile ways of working that are related to clinical consultations, but also where staff are based, particularly for organisations that are multi-site. We've been quite archaic, I think it's fair to say, in England about doing virtual working more generally, and I think that's prevalent across a lot of public sector. And then the other thing is about how we behave more like systems rather than individual organisations. So I think it's great that we've been thinking across London and our sectors about where our resource lies and best is deployed to meet our demand. And I think for too long, health systems have had fixed resource and patients have a particular set of demand, and we try and match that as best we can, but we don't make much change on a day-to-day or week-to-week or month-to-month basis. We deliver what we deliver because we're constrained. But actually what we're seeing here during this pandemic is that we're using new inputs and intelligence very regularly, hourly, daily, about what is going on and being able to try and flex our system to do that. Now, do I think that's sustainable? That's $1 million question about whether we'll just all burn out because every day is a new model. But I do think we could bring the principles of thinking a bit more intelligently about how do we operate our resources across systems better and join up, and also do that more in terms of patient need and what is going on out there, rather than just seeing our hospitals in particular as passive recipients of this type of demand and activity. So I hope there will be a reset and a thinking. And I do completely agree, though, that the pandemic, whilst no one would want it, is the thing that we need to focus on, getting everyone through this as safely as possible.
Excellent, thank you. Just to touch back on the constrained resources that was mentioned earlier, a large part of the work that ISQua does and the direction we face is towards lower middle income countries. So what key messages would you feel that or key learnings have come out of all this that we could possibly apply towards the lower middle income countries?
So I think it depends a bit on what level of the system you're in, and it's a long question that we could spend a lot of time on. But fundamentally, what we're trying to do in every country in the world is two things simultaneously. And everybody with a deep public health training understands this, and I've had to learn it quicker than most. We're of course trying to treat the sick. So we have to give the best care we possibly can to those who fall ill as a result of this virus. The vast majority of people who get this virus will not fall seriously ill. So you cannot allow your healthcare system to be overwhelmed with them. You have to keep them at home, and you have to give them good self-care advice. And that's the same self-care advice as if they had flu. You cannot see all of them in your healthcare system. It is impossible. Most of the research suggests that with the virus in the wild, with no population measures, 80% of the population will get it. So you have to only treat the ones you have to treat. Now that's easier in some systems than others, with access to some systems than others. It's a real challenge in both low middle income countries, but it's also a challenge in some public-private split systems like the US or Australia. So it becomes quite difficult to know what to do with them. So you have to give the best care you can for those who require it, not for those that don't. And the second thing you have to do is you have to treat the population at the same time. And the population means population level measures. Now, some of you will not have influence over those population level measures, but if you do, the advice has got to be very strong to those who lead the countries and states who make those choices about when to go into lockdown, for lack of a better description, when to release those barriers, how to release those barriers, what you should do with testing on the way in, what you should do with testing on the way out. And all of that is becoming more and more known as we learn how to do this around the world, including in the UK. We're making mistakes, of course we are, and we'll continue to make mistakes. But we're learning all the time as we work on what should we do with the intensive care capacity? What should we do with the testing capacity? What should we do with the transportation in the country? How should we limit that to just essential workers? So the same lessons apply in low and middle income countries. The challenge then is implementing them within that resource setting. But I think the key is treat the sick, and treat only the sick you have to treat, and at the same time manage the population in order for your health service to cope with that surge.
Excellent, thanks, Jason. We had Dr. Francesco Veneri on with us last week, who gave his account from the Italian frontline, and he mentioned that one of the main failings from Italy was communication. There was a clear lack of communication and direction from the beginning, which took a while to get sorted out before they were able to act. We have a question from Susie, who's asking, what communication channels are you using to keep engagement and support to staff?
So I can speak from the hospital that I work in. We're using a whole range of things, and we're really lucky that we've got somebody with behavioural insights expertise embedded in our organisation. They were working in the improvement team before we entered into this pandemic, and they've been really helping us to think about how do you nuance messages for staff that are often about behaviour change or about trying to convey or communicate a difficult message or decision about why all of staff at this point in time can't get testing, but what is the benefit to those who can, and how does that help others, and why we have to manage that in a particular way. So thinking about our particular messages that might be difficult about when you should and don't need to wear personal protective equipment, or which groups of staff or patients do need testing, or how we're making choices about the types of services that we need to continue and maintain and others that we won't be able to maintain. It's really important not only to communicate with our staff, but our patients. So we're thinking about using behavioural insights in some of that messaging. We're also thinking about all of the communication channels that we use. So we've been fairly traditional, I think, in healthcare, often using an intranet to push information out passively, or put something on a screensaver, or stick something up on a poster that will stay up in an area and get completely outdated. With the technology that we have, we need to be thinking in different ways about communicating with staff, gathering information and sending it out as well, and thinking about the use of apps, about the use of social media, podcasts, videos, and trying to get that communication in practice into real time is a real challenge. And I think some of the things that probably Jason will be able to share, but some of the things that I've noticed from social media is where you make stuff really accessible through the use of infographics and other things. People really find that valuable. So it's how you get that information turned into ways in which people can understand stuff very quickly for them and make sense of guidance or protocol or policy, etc. But I think Jason is the absolute master of communication, so he'll better pick up that better than I can.
If only that were true. It certainly landed on my lap, whether I wanted it or not. I've had to learn a lot about how audiences receive and learn, and that is not the same for everybody. So in the UK, not everybody listens to Radio 4 in the morning and the big political interview that happens at 8 o'clock. It turns out most people listen to local radio stations and read the local papers, whether they're in Newcastle or in Aberdeen. So we have had to very carefully think about communication with the whole population. And remember, when you communicate with the whole population, you also communicate with healthcare workers and their families. So this is such a large project to deal with this pandemic that I've been on, would you believe, the chart programme on Scotland's radio stations. I mean, that's preposterous. I've been on the comedy football programmes, and I've been on the slightly posher versions of the radio in the mornings doing phone-ins. So we have tried to cover pretty much every demographic at every point with every single piece of media we possibly can. And when you think you're done, you do it again. So we did young people. We've done older people. We've done TV adverts. We've done infographics for staff about which PPE when. We've done infographics with hotlines, websites where people can get advice for each individual thing. And just when you think you've done it all, something else comes. So today, I was asked to do something for Scotland's hospice community. So we haven't done anything for that community. They're taking the generic guidance and they're applying it, and they're doing really well. But yesterday, Scotland's Children's Hospice set up the first ever virtual hospice service in the world. So they moved a lot of their care and work online. So that's for families, it's for kids. It changes the nature of what they're doing. So they're using technology like this, but they're using it for kids who are in end-of-life care and their broad family members. It's fantastic work. It's heartbreaking, but we have to be able to communicate with them and their staff, give them good guidance, give them good advice, and support them. And tomorrow, I'm quite certain I'll get another sector that I haven't thought of that we will be able to engage with. The other lesson I've learned very quickly is to use trusted partners. You cannot do it all from the health system. You have to use other people who are trusted by each community. So if you are working with the independent living community in Scotland, the very strong contact we have with the disabled, what we call the independent living community in Scotland, you need to use the independent living community to share those messages. I can't do it. I can advise and I can help with the guidance and I can maybe interview the independent living people, but I can't do it by myself. I am not a trusted partner. They have to do that for their tribe, for lack of a better description. So use tribes to teach tribes is the other communication advice.
I think the other thing to also just say is that many of the messages we're trying to convey are sort of once-in-a-lifetime things. The stuff we're talking about, the suppression measures, lockdown, and the things that people need to do about distancing, isolation, these are all quite extreme public health measures, and they take a lot of communicating to people, not only for them to remember and reinforce and make it part of their routine, but lots of people don't necessarily feel that we should be told at a population level that we should behave in certain ways. That doesn't necessarily chime with the way people live their lives in the UK, and yet these governments are having to make very tough decisions about saying you will behave in this way. And so I think on many levels this is a very complex pandemic to manage, and it's great to be able to have skillful communicators with the right channels thinking about what is the message, how do we want people to really behave and do something different as a result of what they've heard. And I think that's, you know, classic of what we always want to do when we're trying to think about change. It's just that this is really amplified, because if we don't get this right, people will die, and that, I think, is the imperative that has never been as strong as this before.
Excellent, thank you. I believe we've touched on this a little bit earlier, but we have a question asking, how would you prioritise the viral testing strategies given the lack of test kits worldwide?
So that's very topical. Our First Minister has just been in Parliament giving a statement just in the last half an hour before I came on here about this very question. Testing is becoming the big iconic question for governments all over the world. Presently, we have antigen testing, remember? So this is virus, yes or no. So therefore, it's only helpful in some settings. So we have prioritised 3 levels of that antigen testing, and we're moving the capacity as fast as we can. Group number 1, those who are sick and in hospital. So those who are symptomatic, to help us decide how and where to treat them. Group number 2, surveillance. So we want to know how big this virus is across the UK, and we want to track it so we know what to do with the population measures. And group number 3, testing for key workers, because we have locked those key workers away. There's a little bit of an exaggeration. In Scotland, 7% of our health and social care workers are off. They're off mainly because their household is isolated. They are often not sick themselves. So a test for that household would be really useful for us. And that's going to be our next set of priorities. After that, when we double, triple our testing capacity across the UK, and we start to get antibody testing, a different type of test, so have you had the disease and recovered from the disease, not do you have it on Tuesday, that will then be a game changer about how we back our way out of this viral curve, so that we can start to switch off the population measures and put people back into this world safely. But testing has become a big challenge because of kit, resource, and people. So we're now using our university laboratories as well as our health service laboratories. We're doing links to the private sector companies, where everybody is working on this as fast as they possibly can.
Great, thanks, Jason. So our next question from Nazia, do you have any quality measures or guidelines that we can use in quarantine centres or quarantine areas?
So some of the things that we've been looking at locally in my organisation is, how do you understand and measure quality during a pandemic such as this, and what are some of the basic data sets that you collect anyway, and how might you need to enhance them? So I'm sure there'll be other people on the webinar that can hopefully share through various mechanisms that include Twitter as to whether they're following specific frameworks. We've looked in a few different places at what WHO recommend, and also taking some of the learning from places like Red Cross and others who are looking at how do you measure quality in conditions that are not your optimal, say, usual system. So what does quality look like? And Peter Lackman has spoken recently on that as well. So there are lots of experts that think about quality in more of a sort of field setting or an emergency setting. The things that we're looking at locally in my hospital trust are trying to understand some of our basic measures like mortality and try and interpret that. So when we see mortality rates going up, understanding whether that is related to people being more severely ill with other diseases and just presenting later, or whether that's related to the increased number of cases of COVID and that's the expected amount of mortality that we would see, or whether there have been any issues or incidents with quality of care that might be changing the mortality rate in which we see. So you can see it's quite complex, because we could take a measure or quality statistic that might mean something in one setting or scenario, but once you're looking at it through the lens of the pandemic, might mean something else. So what we're doing is reviewing a lot of our quality measures and metrics at the moment to see whether they tell us the right things about our system. So, for example, when you're looking at rates of your staff sickness and absence, how are you using that then to understand if people are actually sick? Are they isolating? Are they off for other reasons that might be related to psychological trauma or anxiety as a result of the workplace stress that they're having at the moment? And what do you do with that? Because we want to collect data that's meaningful, that will make us change what we're doing and do something better as a result. So it's a great question. What does quality look like during COVID? I think could be a whole webinar in itself. But we're starting to look at how we might interpret some of the data that we routinely collect and then understand what some of the new data sets that we might need to collect during this time would be.
Excellent. Thank you, Dominique. And then finally, I'm conscious of the time, and I know you're both extremely, extremely busy and you need to get back to work.
This is work.
Well, true, yes.
This is real work.
Well, that's what I was going to ask. How do you feel that ISQua can further help, spread information or key messages or just general quality and safety within this current climate?
Seems to me there's a speaker and a receiver role for ISQua. I think there is an educational role like this in a way that is unique. ISQua has a unique network of players from around the world, and things like this done in an agile type way with question and answer. I hope today's is helpful, but I imagine there are other helpful ones that could be had, and pushing that stuff we talked about earlier about fast quality assessments, learning, getting that out, perhaps with other think tanks from around the world, other organizations from around the world, in conjunction with the WHO maybe. Remember, it has to be contextually adaptable. So the WHO covers 194 countries. So what they say for Somalia may not be the same as what we're going to do in Scotland. So we have to not be fixed. We have to be advising and then contextualizing. The other thing I think ISQua can do is it can use its network to send information upwards. So it can gather information and intelligence from its members and friends so that the governments, the leaders, the countries can then adapt to whatever it is you're hearing and learning. And perhaps that's around networking individuals with individuals. So we've had a long conversation today, not me, but some of my guys have had a long conversation with a delegation in the UK from Wuhan in China about what they have learned, what they did, and we're going to do the same with Italy, with South Korea, with others. So I think there's a convening role that ISQua can have as well.
Yeah, I'd echo that. I mentioned at the beginning, or it was mentioned, Brian, that I also work at the Health Foundation. Similarly, these organisations like Health Foundation, ISQua, IHI, and others, I think, have been very thoughtful about how can they add value during these types of unprecedented situations. And I would completely agree with Jason. I think there's a convening role as to how you bring people with the expertise together to share through networks when they are busy and pressured, and how we do that thoughtfully, because these networks exist. And so it would be great to utilise them, particularly international ones, and how we're getting the best evidence and practice into the bedside, into the organisations, into the systems that need to make decisions. So the synthesising, the horizon scanning, the learning and the sharing. And I think that support, that evidence-based approach, the networking and the learning is really important. And then some direct resources. So wouldn't it be great if a group of people, as a result of this webinar, did put heads together and think about what does a quality framework look like for their types of settings or organisations in a pandemic situation. I'm sure stuff like that exists, but pulling that together, so bringing some great minds and doing some actual in-action learning and looking at the impact of that is really important. And so I think all those people who are very much involved in these organisations, often not necessarily on the front line or doing the kind of the day-to-day acute facing work, are looking for roles to play. And I think hugely important expertise sits in organisations and networks like this that could be very supportive right now.
Excellent. Thank you so much. And I think we're just going to start to wrap up there. So on behalf of ISQua, I just wanted to say again, thank you so much, Dominique and Jason, for joining us today. Brilliant talk, brilliant session, and a great insight into the UK's experience, which is also applicable all over the world. Looking at our attendee list here at names and countries, we've got a huge representation. So I've no doubt that what was discussed today will be extremely beneficial to everyone on the call today. Just some closing notes for everyone to remind you that the recording of this will be available shortly on the ISQua website. Please feel free to pass it on to anyone that you feel may benefit from the information and share it within your networks. Again, sincerest thanks to Jason and Dominique. Fantastic presentation. Thank you to everyone who joined us here today. And just a quick message, if you haven't already seen, we have our page on COVID resources on the ISQua website, which has lots of, collated a lot of information regarding it in terms of webinars, papers, talks. And we also have an upcoming webinar tomorrow with the Seattle Children's Hospital's Interim Chief Medical Officer, Dr. Ruth McDonald, and the Medical Director of Infection Prevention, Dr. Danielle Zer. Finally, what we've really noticed is the strength of the ISQua community and the healthcare community all over the world in general in response to this crisis. The ISQua community itself has been absolutely phenomenal in reacting. So please, if you'd like to join ISQua, help support the community, by all means do. Yep, that's it from me. Again, just thank you so much, guys, for joining us. We really appreciate it, and that was an excellent session.
Thank you.
Thank you.
Okay, thanks now. Have a good day.